What's the difference between lymphoma and CLL? Lymphoma is solid. Lymphoma is solid, and CLL is liquidy. It is in circulation. Neck pain and swelling. And he's got a mass in his cervical area that's not tender, not red, not warm. No rubor, no calor. No redness, no tenderness. And that's bad. You see, if I walk up to a patient, I walk my hand on their neck and I press on it and they go, ow, ow, ow. I go, congratulations. They're like, you asshole, what do you mean congratulations, you hurt me? Yeah, because as long as it hurts you, you don't have cancer. The lesion persists despite antibiotics because one of the things is, what's the organism most likely to cause infectious adenitis? It's actually Staphylococcus. So what you can do if you don't know what's there, you can treat it with anti-staphylococcal drugs, oxacillin, cloxacillin, dicloxacillin, and ampicillin, or first-generation cephalosporins. Oxacillin, cloxacillin, dicloxacillin, or ampicillin, or first-generation cephalosporins, and see if it changes in size. If it doesn't change in size, or it's rubbery and non-tender, then it is a biopsy, but here's your number one first question. For lymphoma, it has to be an excisional biopsy. Needles don't work well for cancers. Needles work well for infections. Needles work well for TB and for fungi. But needles don't work for cancers because in order for you to see lymphoma, you can't just see the individual lymphocytes. The individual lymphocytes in lymphoma look normal. So what you have to do is see the architecture of the whole node. Now, once you know, and you see that it's lymphoma, the architecture of the whole node and how the lymphocytes look in relationship to each other, the same way an individual lymphocyte in CLL looks normal. An individual neutrophil in CML looks normal, looks like a normal neutrophil. You have to now be sure that it's local. We found a neck lesion, right? So if this is just in the neck, you treat with less chemotherapy and radiate the neck. And 95% will get better, because that's stage 1. If it's 2 locations above the diaphragm, you still can go less chemotherapy and radiate. 90% cure. But if you scan the pelvis and the abdomen, and you find that you've got lesions in the pelvis and the abdomen, that's stage 3. In stage 3, where you can't radiate it, radiation doesn't help, and you have to use more chemotherapy at higher dose. So stage 3 and 4 disease, which is 2 sides of the diaphragm, or widespread disease like into the marrow, needs higher dose and more severe chemotherapy. And the cure is less. So the other tests we do a chest x-ray and a chest CT, abdominal CT, scan the whole body with CAT scan from top to bottom to be sure that it's really localized just to the neck. You do a bone marrow biopsy to be sure it's localized just to the neck. What you don't have to do, lymphangiogram or laparotomy or extinct tests that used to be used before CAT scans were so good. So you have to go as far as making sure that it is not in the abdomen, the pelvis, or the bone marrow to be sure that it's really localized to the neck. And once it's localized to the neck, then you can treat it with a little radiation and a little low dose of chemotherapy. The types of prognosis. Remember, your choices here, you've got to make a diagnosis, give a prognosis, and look at adverse effects. And that is more true than anything for the subject called lymphoma, where you have to be able to say to people, what's your chance at survival? So lymphocytes are good, right? So if you got, lymphocyte predominant, that's good, because lymphocytes are good. So if you got a lot of lymphocytes, that's good. So it's the best prognosis. So if lymphocytes are good and you don't got any lymphocytes, well, that's bad. That's bad, because lymphocytes are good and you don't got any lymphocytes, it's bad. And what's the prognosis on mixed cellularity? The prognosis on mixed cellularity is kind of mixed. So, back to this case. Remember, we're presenting with a guy who's got cervical lesions isolated. Now we're telling you that the chest x-ray, the chest CT, the pelvic CT, the abdominal CT, the bone marrow showed no other lesions, is isolated just to the neck with Hodgkin's disease. And isolated just to the neck with Hodgkin's disease is radiation therapy predominantly and a little chemotherapy. Radiation therapy predominantly and a little chemotherapy. Radiation. Now, CHOP would not be for Hodgkin's disease anyway. CHOP, cyclophosphamide, hydroxyadriamycin, vincristine. prednisone. Cyclophosphamide, hydroxy, adriamycin, vincristine, prednisone, that would be for non-Hodgkin's lymphoma. So if it's localized, radiation and a little chemotherapy. Now, what if you do find something where you find that this person has lesions, you scan the abdomen, the pelvis, you did the bone marrow, he's got lesions that are stage 3 and 4, and you found that the person has Hodgkin's disease that's spread beyond the range of just radiation. Hodgkin's, that's just beyond the range of radiation alone. What if you find lesions elsewhere? Bone marrow, pelvis, then adriamycin, A, bleomycin, B, vinblastine, V, dacarbazine, D, ABVD replaces the mop. ABVD, better than a chop. CHOP is for non-Hodgkin's, and ABVD for my Hodgkin's. Now, if you relapse after radiation, you radiated the neck and it came back. You radiated most of the rec and gave a little chemotherapy, came back. You radiated and came back. Then we go, it's Hodgkin's disease. ABVD, adriamycin, bleomycin, vinblastine, dacarbazine, after radiation therapy. Now, this one's much worse. What happens? You chemotherapied the guy, you gave him ABVD, and it relapsed. Well, first of all, you can't go back to radiation because it was too widespread to do radiation. CHOP is the wrong drug. CHOP for Hodgkin's disease would be a bit like giving, the wrong antibiotics. Remember that they have sensitivities of these cancerous cells in the same way E. coli is not treated with oxacillin. E. coli is not treated with oxacillin, and Pseudomonas is not treated with oxacillin, and Staphylococcus is not treated with aztreonam. So if you relapse after chemotherapy, how do you give someone a supramaximal huge dose of chemo? You do it by giving a bone marrow transplantation. Allogeneic, or if that's not available, autologous. You take their own bone marrow, you pick out the normal stem cells with CD34 antibodies, you give them a ton of chemotherapy, radiate the crap out of them like you put them in a machine that gives them essentially a fatal dose of radiation. And then when all those cells are cleaned up, remember chemo and radiation, cleaning up all the cells, you transplant in their own bone marrow or another person's marrow. If the patients receive chemotherapy and is pancytopenic, what's the type of transfusion? Well, did you know that a blood transfusion, although it has a small number of white cells, those white cells in a transfusion are still alive and might attack the recipient? Second is that you don't want to be building up antigens. Do red cells have antigens? Not exactly. What red cells have is they have blood grouping, but that's not the same thing as saying antigens. The antigens are in the white cells. So what you want to do is you want to filter out those white cells. You want to wash off the antibodies and filter out those white cells so that you don't build up antigens. Now, after you undergo radiation, remember we said diagnoses, prognoses, and adverse effects? What happens as a complication of radiation of the neck and the chest? If thyroid disease was here, thyroid disease could have been a choice for radiating the neck. Thyroid disease is not here. So the most common wrong answer is saying acute leukemia. Radiation causes solid tumors. Now, you're not radiating the brain, and you're not radiating the ovaries. You're radiating his neck and his chest. So radiating his neck and his chest, the answer could be thyroid cancer, lung cancer, and sometimes breast cancer. But radiation by itself, just to focal areas, you see, that's the issue. You're not radiating the total body. If you're radiating a focal area, you get a focal cancer. So radiation causes solid organ tumors. Chemotherapy, however, the most common treatment-related complication of chemotherapy, the most common adverse effect, it's not peripheral neuropathy, vincristine, vinblastine. It's not lung fibrosis, bleolung. It's not cardiac with adria or daunorubicin cardiac toxicity. 99% of people who undergo combination chemotherapy, CHOPs and MOPs and ABVDs, become chemotherapy here. So chemotherapy, but this is now the answer to this question is leukemia. But overall, the most common, much more, because the leukemia is at 1% a year. What's the most common, more common than the leukemia? 99% of people become sterile. So a lot of people, you notice, first of all, sterility is not one of the choices here. If sterility was on the choices here, sterility would be the answer. Lung and breast is for radiation. Hypothyroid is for radiation. 1% a year develop aplastic anemia or acute leukemia, but almost everybody becomes sterile because it cooks your gonads. Now, which are more vulnerable to the chemotherapy, men or women? Men are more vulnerable because if you're a woman and you get radiated, you get your ovary, you get chemotherapy, your ovary gets chemotherapy, but you only make one egg a month. And it's not even fresh. It's been there a long time. You throw it up. If I'm there, I get it. If not, screw you, come back next month. But testicles make 60 million baked fresh daily. So because of the rates of cell turnover of male testicles, men are much more vulnerable to infertility with chemotherapy. Now, of the choices here, acute leukemia was the most common chemotherapy, but if they actually ask you just in general, the most common adverse effect, it's infertility. 42-year-old woman, fever, weight loss, night sweats. So fever, weight loss, and night sweats automatically means you need chemotherapy. Fever, weight loss, and night sweats for lymphoma automatically means that you are going to need chemotherapy because it's either stage 3 or 4 disease that needs chemotherapy or people with, quote, B symptoms. And the B symptoms is fever, night sweats, and greater than 10% body weight loss. Fever, weight loss, and night sweats. Now, these lymph nodes are palpable in the cervical area and the axillary region. So we already have 2 spots. And an excisional lymph node biopsy shows non-Hodgkin's lymphoma. Now, because there's B symptoms, we know automatically that you need to have chemotherapy. You have to go as far as the marrow to stage it. So this is stage 4 disease. So this person is going to need chemotherapy, and the chemotherapy for non-Hodgkin's is CHOP with rituximab. If the CD20 antigen is positive, CHOP, cyclophosphamide, hydroxyadriamycin, vincristine, prednisone. Remember, high-dose steroids have anti-leukemic effect. That's why we use dexamethasone for myeloma. So high-dose steroids actually kills leukemic and lymphoma cells. And remember, lymphoma is just a solid CLL. So this person, because there's involvement to the bone marrow lymphoma, it's stage 4 disease. But even if the bone marrow was negative because of fever or weight loss or night sweats, the B symptoms implies microscopic spread outside of the lymph nodes, and you'd be chopping them anyway. CHOP here, cyclophosphamide, adriamycin, vincristine. Vincristine, vinblastin, peripheral neuropathy. Adriamycin, cardiac toxicity. Cyclophosphamide is hemorrhagic cystitis. What can you do to prevent the hemorrhagic cystitis of cyclophosphamide? You can join Mensa or give Mesna, M-E-S-N-A, give Mesna. The further test, remember that the CHOP has been around for going on 50 years. CHOP has been around a long time. And there's not been anything really much better than these medications. It can alter the dose, so a little bit, but the actual gut, the guts or the center, the core of the chemotherapies, the core of the chemotherapies is for non-Hodgkin's is still pretty much the same. And the other test is that if your CD20 is positive, you add rituximab. Now that's become an easy question. It's been standard for 20 years. CHOP-R. What do you do if you relapse? Oh, well, since you're relapsing after chemotherapy, the same as it is if you relapse after chemotherapy with a person who had Hodgkin's disease. If you relapse after radiation, use chemotherapy. If you relapse after chemotherapy, you can't just retreat, you're resistant. It's like saying you've got urosepsis with an organism resistant to the drug you're on. So you do a bone marrow transplant to bump up the dosing. You do a bone marrow transplant. All right, lymphoma. And remember that the specific chemotherapies, I would say the most important thing for you is the adverse effects. So let me take a point here. The people who write the MixApp don't write the boards. And the Hematology Oncology section of the MixApp is amazingly over-detailed for what I think a general internist needs, and it's certainly over-detailed for what you need for our boards. That's why the Hematology Oncology MixApp is often as long as cardiology, for what's a smaller section of the boards and in too much detail. So that's why this is the only section, oncology I say. Hematology will cover everything, but oncology is going to be the only section in the whole course, in the whole book, where there are going to be some things in the MixApp that are purposely not here because they're just not going to, I'm not going to waste your time and brain space with certain of those extras in the oncology MixApp. The oncology MixApp is over-detailed. What we're going to tell you here is what you need to know without torturing you. I'll see you soon.